All right. Well, I think I might start this exciting event this afternoon, and I'd like to welcome everyone that's in the room and everyone that's joining and starting to join online as you're admitted from the waiting room there. Thanks very much. We're having a great show this afternoon all about virtual care for older Australians in the community. I'm Professor Meredith Makem, Associate Dean for Community and Primary Healthcare in the Faculty of Medicine and Health, and I'm just really delighted to welcome you all here. So firstly, I would like to, of course, acknowledge the traditional custodians of the country that we're meeting on today, the Camaragal people of the Eora, and we honour the memory of their ancestors and elders past and present. And we recognise the importance of the land and the waterways as an integral part of the people's health and well-being. So I'd also like to acknowledge those traditional custodians of the different countries that our guests online are zooming in from today as well. Now, as well as my role as Associate Dean with our Faculty of Medicine and Health, I'm a GP clinician researcher working in virtual care and also a local GP here in the Northern Sydney region. So I'm really excited to have colleagues and friends from our local primary health network who are kicking off our talks today with our other distinguished speakers that you'll hear from later. But before I start to introduce our speakers, I wanted to talk very briefly about the work of the Community and Primary Healthcare portfolio and the network and how it fits within the work of the Faculty of Medicine and Health at the University of Sydney. So our faculty, to give you a sense of it, is the largest within the university, and it has over 12,500 students. It has around 4,000 staff, academic and professional, and also around 3,800 affiliate staff who, many of whom are clinicians who are working in LHDs and affiliated with many of the research institutes and centres associated with the university, such as the Kolling Institute, where some of our speakers today are based. We actually have 7 schools that are delivering medicine and health degrees across our faculty. All of these activities operate within groups that we refer to as precincts. And these groups are geographical groups that cover the regions of Northern Sydney, Western Sydney, Central Sydney, and also something we refer to as our rural precinct, which comprises our 3 rural clinical schools in Lismore, Dubbo Orange and Broken Hill. And a quick shout out to the people online who might be joining us today from our rural precinct. I saw a few of you zooming in and other parts of New South Wales. It's great to have you all online today. So about 3 years ago, we began a portfolio in the Faculty of Medicine and Health that we call the Community and Primary Healthcare portfolio, and our team is responsible for driving community engagement and fostering the principles of primary health care within our teaching and our research operations. And we created a strategy with all of our community and primary healthcare partners, such as PHNs across New South Wales and also Health Consumers New South Wales. And we also created something that we've called the Network for Community and Primary Healthcare, which is a place that people who study and work with our faculty and other community organisations and consumers interested in this area can come together to share ideas that support better primary healthcare for the community. So if you're not already, just quickly zoom that QR code there, because our network for community and primary healthcare is open to everyone to join. We currently have 450 members, and if you scan that and become a member, you'll get updates about our regular news and events. And today's event has been really expertly coordinated by our networks team at the faculty, working closely with colleagues from Arabanu, our northern precinct based here at the Kolling. And I'd also like to offer a really big thanks to other organisations who've contributed to supporting today, including Sydney North Health Network, Sydney Health Partners, Geriatric Medicine and Virtual Care Clinical Academic Groups, and colleagues from Geriatrics and the Virtual Care Service at Royal North Shore Hospital. They're all here to bring us a taste of virtual care in the community for older Australians, and they're going to be showcasing innovation that's happening right here in our local region. So to begin, I am going to invite Professor James Elliott on behalf of the leadership team at Arabanu, our Northern Precinct, to say a few words of welcome. James is the Academic Director of the Kolling Institute and the Academic Director of Allied Health and Public Health within the Faculty of Medicine and Health. That's a mouthful, isn't it? And over to you. Thanks very much, James. I'll just leave that said.
Yeah, no, thank you very much, Professor Maker Meredith. It's great to be here with you, and I appreciate very much the opportunity to join everyone here today. A few brief words, if I may. I'd also like to acknowledge the traditional custodians of the land on where we meet here today and pay my respects to elders past and present. You may or may not know that the Kolling Institute is the oldest research institute in New South Wales. We're entering our 104th year. And within that, we are now in a little blip of our history. We are in year 4 of a 5-year research strategy. And I'm really pleased to say that the work of our team across the Institute has some real measurable impact that we're really proud of across that strategy. But in the spirit of always wanting to do slightly better, we're now drafting our next research strategy. And part of that, won't surprise you, is our involvement with the community and the primary health network and our colleagues around the local area. So it's with that enthusiasm that I really want to say thank you very much for allowing us the opportunity to host you here today. It's really kind of exciting to bring people together in one room, but also online to talk about some important things across the community and across primary healthcare and digital health innovation. And I'd also like to welcome all the people online who've joined us here today who are coming from other precincts across the northern or across the University of Sydney that Meredith referred to, and certainly across the primary health care network. I'm really especially looking forward to hearing more from our team members and our colleagues joining us from the Sydney North Health Network, local PHN. Clearly, they are leading work in innovative virtual healthcare, and it's also going to be very exciting to hear from some of our colleagues here in the local health district who are working closely with Sydney Health Partners in this space and leading innovative clinical services in our hospitals across the Northern Sydney LHD and Arabanu. I really hope, and I think all of you hope, that this event provides us all an opportunity to bring our different perspectives together as we sort of collaborate and talk about ways to collaborate and bring our different perspectives across research, across hospital-based services, and certainly community care. And from that, how can we all learn how to better assess, but also manage an aging population? So it's with that, Meredith, that I want to just welcome everybody to the Kolling Institute. The Kolling Institute itself, we occupy 6 floors in this particular building, which happens to be called the Kolling, which is quite a unique thing. Not everybody knows that. But we work very closely with our health partners, and we're very excited to have you here today. So thank you very much for the opportunity.
Okay, so I'm going to hand over now to our first presentation, and I'm going to welcome our speakers from the Sydney North Health Network PHN team. A special welcome to Kevin Barrow, the CEO of Sydney Northern Health Network, and Deborah Palavicini, who's the General Manager of Primary Healthcare Engagement, and also to Pan Ting, our Sydney North Health Network Digital Health Manager. So if Kevin and Pan, if you'd like to come up, I think you're speaking to us today. And I should say, and welcome to John Pettigrew as well. He's from the team as well. Thanks, John. And I think together, Kevin and Pan are going to speak to us about their virtual care model for residential aged care homes. So, please, let's move that for you. There we are.
One more time.
There you go. Okay.
Well, thanks very much, and welcome everybody. My name's Kevin, so I'm the CEO of the Sydney North PHN. Been in the role for 7 months, so very shortly I'll hand over to Pan, who's been doing the work in this space, to give you a bit of detail around some of our key programs. I'd also like to acknowledge the fact that our office is based in Chatswood, which is the lands of the Camaragal people, and pay our respects to elders past, present, and emerging, and acknowledge each of you are meeting potentially on different ancestral lands. PHNs. So when I took this job, my mum asked me to explain what a PHN was, and so here's whether or not I got that right. So the words behind you are actually on the government website. There are 31 PHNs across Australia. There are 10 PHNs that work within New South Wales, the largest populous state, and there's one in the ACT. PHNs at their heart are place-based organisations, and we serve 3 primary functions. The first one is to support primary care providers. So that may be GPs, allied healthcare professionals, and work to support them in their practices That might be practice education, it might be quality improvement, it might be data analysis, it might be the work that we're doing here today. But at its heart, it's about supporting primary healthcare and allied healthcare professionals to do their jobs better. The second thing we do is commissioning. So firstly, what we need to do is understand what key healthcare needs exist within our area. So we're very place-based, very specific to North Sydney. Now, I'll show you some data on North Sydney shortly. But at the end of the day, what we're about is understanding where pockets of inequity exist and commissioning services to help close those gaps. Now, North Sydney is a very wealthy area overall, but there are significant pockets of inequity that we need to deal with. And our role is to commission services to improve that level of health equity. And the third thing we do is a role of integration and coordination. And there is a quote from the National Health Reform Agreement, which is sometimes called the National Hospital Reform Agreement because it's usually more focused on hospital reimbursement than it is on broader healthcare. And it talks about the role PHNs can have as a neutral player within the community. And by neutral, I don't mean dispassionate. We're very passionate about what we do, but we are not sitting in here with a vested interest. We're not a professional provider. We're here to support the community and better integrate care. We, unlike many PHNs, are made up of close to 1,800 members. So some PHNs would have only 8 members. You could fit them around the dining room table. And that makes AGMs a lot easier. But our AGMs are more representative of the community. So you can see a breakdown. So a lot of general practitioners, allied healthcare professionals, psychologists, and others, nurse practitioners. And that gives us a lot of voice. So we hear a lot of member needs and concerns. And that makes us quite unique from a governance perspective. Now, North Sydney we're sitting in, we all know North Sydney. Our catchment's about 1 million people, so it ranges from sort of the bottom areas, Hunters Hill, all the way up to Palm Beach, across to Hornsby and back around to Ryde, which pretty much perfectly overlaps with the LHD, which is unusual because many PHNs overlap with multiple LHDs. And so it means that we should be working very, very closely with the local health district because there's no excuse if we do not. I mentioned before that we are significant in terms of population, around 1 million people. And you can see the breakdown here. We have a higher core population than is average across New South Wales and Australia, a lower Aboriginal and Torres Strait Islander population, although it is significant. And then just a few other facts that you can see here. In terms of elderly and older Australians, we are similar to the average, but we are ageing faster than other PHNs, and we actually have more residential aged care homes in our PHN than any other PHN across Australia, which makes Pan's presentation very critical for us. We know that we very much struggle to have GPs visiting aged care facilities, and we need to work much better to enable that to occur because it is extraordinarily challenging for your average general practitioner, particularly the way the reimbursement systems are set up within Australia. The final thing I'll say is we're doing also our 5-year strategic plan. And at its heart, place-based organisations mean we need to understand local community and work to assess local need. So that might mean that we put in a headspace in Brookvale, but it might also mean that we need to support a men's shed in Mona Vale. We have people living in caves in the Kringai Chase National Park. And a lot of people do not know that, particularly when they say, oh, North Sydney, you're a very wealthy area, you don't need any support. The reality is there are pockets of disparity. And for us, our challenge is like heating up a bathtub with a candle. We have to apply limited resources. So our budget's around $50 million. Like all LHDs, probably a little bit over $2,400 million, most of which goes to fund hospitals. For us, it's about choosing very wisely where we invest. And this is an area that we've chosen to invest in. So with that, I'll hand over to Pam.
Thank you, Kevin. And thank you, Meredith, for hosting this. I'm excited to share the SNHN Residential Aged Care Virtual Care Service today, or we call VCS. So the VCS is really a PHN funded activity that's part of the Commonwealth Aged Care Funding Schedule. And it's really there to support our residential aged care homes to increase availability and use of telehealth care for our aged care residents. It's part of the Australian government's response to the Royal Commission recommendations, specifically 56 and 63. And it helps to address 5 aged care quality standards. So we chose to commission this service very, very unusually, I guess, in the country. Other PHNs have chosen to give individual grants to their care homes. So we chose to commission the service going through a procurement process with a competitive tender. So it's intended for use by our aged care home staff, their residents, and primary care providers, especially GPs in the Sydney North region. And it's completely voluntary. Okay, so what is our VCS journey so far? So the brief has obviously been guided by the funding policy guidance and requirements from the Commonwealth. We did a needs analysis and digital capability surveys of our aged care homes just to look at how we prioritize the rollout of the particular service. We did some research and a landscape analysis by speaking to vendors and really looking at what the virtual care solutions are out there. Obviously, couldn't do a comprehensive one. And then into the commissioning process. So we ran several co-design sessions which brought stakeholder cooperation. We prototyped the service kind of internally and what it looks like, ran the tender, and then that resulted in a contract with Health Teams. So that's a local company, startup company in Sydney. We're in the middle of the rollout at the moment. So all the 102 aged care homes in Sydney North region that are eligible, 40% are participating at the moment. And then we're in the middle of instituting some strategies to really drive the implementation and more use of it. And then I'll talk a little bit more about evaluations after. Okay, so what did the needs and capability analysis told us? Among other really interesting stuff, at a median, each GP service 12 beds, up to as high as 1 GP to 44 beds, which is pretty awful. Virtually most of them said they wanted more face-to-face consults, and then virtually all of them also said they wanted more telehealth consults. In terms of conducting telehealth care, phone calls predominate, but also video calls, surprisingly, but they're all public-facing platforms. GPs offer the highest number of, healthcare practitioners offering telehealth care with GPs, followed by allied health, private specialists, and then public hospitals, and then after hours. In terms of the platforms being used by GPs, phone calls predominate, followed by FaceTime, Zoom, and Microsoft Teams. And virtually most of them said they really needed more help in terms of telehealth devices as well as stronger connectivity with internet. Some things that came back around the co-design, I guess the most important ones were that the residents really wanted quicker access and more in-person and telehealth consults with their primary care clinicians and specialists. They wanted more data sharing, so better clinical handovers and continuity of care. They want more system integration. So they really want ready access to their residents' hospital discharge summaries, GP health summaries, as well as COVID vaccinations. And then privacy and confidentiality was paramount. Other things around better connectivity, more devices, single login for their providers was really, really strongly came through. Simple bookings and better consult notes. Challenges. They gave us quite a lot of challenges, and interestingly, they have come to pass. Okay, let's delve into the actual service itself. So we commissioned Health Teams. Our contract was signed last year. So the virtual care equipment are actually provided to the aged care homes, and they get to keep it, which is great. Wi-Fi assessments and boosters are optional if they want to. In terms of the service features itself, it's got appointment bookings, reminders, secure video calling, remote vital signs capture and tracking over time, and also clinical alerts. Privacy security, look, there's multi-factor authentication, there's end-to-end data encryption, ISO 27001 compliance, consult notes. If they actually capture that in the platform, it gets sent to GPs via secure messaging or PDF to any clinical system. And in terms of system integrations, My Health Record Viewing and LeeCare, those integrations are both in progress, I believe. This is just a quick tutorial of what the Health Teams platform looks like. So that's like the mobile version of it with all the connected devices, and then that's the secure video calling, and then that's the clinical alerts. Hardware for homes, so mobile trolley, keyboard, mouse, a Jabra speaker, a couple of iPads, and also a SIM for one of the iPads in case of there's any internet dropouts. The remote vital, so there's a 6-in-1. These are all TGA approved devices. There's something called One, which is I believe the most powerful stethoscope in the world still at the moment. And then there's a urine analyzer, an otoscope, and a throat-scope. Okay, so the service, this is a hybrid care model. So the GPs will maintain in-person visits at the care homes, and then they'll use virtual care to assist whenever that's appropriate. So this is what we think the model will be. We think it will support non-urgent routine and scheduled care. So things that can be supported are things like case conferencing, care planning, medication reviews, regular scripting, managing chronic conditions better. So that's where we think that's where it hits. Initially, we think it will be used for during business hours, but really more and more, I think people are asking for more after hours use. And then including family carers where appropriate, and it really is meant to be run alongside existing telehealth services, the great work that the LHD is doing with the Art Grace and Grace program. Okay, in terms of outcomes and that we really like to achieve, the main one is really timely access to primary care for our residential care home patients. Anything else beyond that would be a bonus. So improve satisfaction for the residents in their healthcare, outcomes for providers, so improve flexibility and efficiency, less traveling, more better care coordination and team-based care, and at a population level, hopefully, fewer hospitalizations. We can improve that. Okay, so, education is typically provided in person, but we also offer some live webinars. There's online modules for on-demand training, a few different flyers. So there's nurse's flyer, a general brochure, and then there's also another a doctor's flyer and a family's flyer. Okay, so we also provide an information pack for our nurses and GPs. So that consists a whole lot of different best practice guidelines from the different peak bodies, including RACGP, ARPA, ACRM, and APNA. We also things around the room setup, what's the best practice for room setup, and we kind of gave them a draft workflow as well. Okay, where are we at? The rollout began last June, July. About 40%, as I said, are participating. About half of those have been trained or in progress. So 136 nurses in terms of users, 14 or potentially a few more GPs have been trained. A few hundred vitals have been taken, just under 100 video calls made. Okay, so this is a pictorial of, well, this is a Google Earth map that I created, but it actually kind of shows you the spread of the rollout of the different homes. Don't really have some in the more remote top part of our PHN. Yeah. Okay, I do want to talk a little bit about the systemic and the higher level order issues and challenges that we are encountering. There's a lack of policy directive at the national and peak body level for virtual care, to be honest. And that's really quite difficult. What that means is that it's difficult to incorporate into clinical workflow, everyday workflow for clinicians. There's lack of GP incentives to do telehealth. So there are MBS telehealth items, but they don't really support more video telehealth. Yeah. My Medicare as well. And then funding. So this funding, there's unclear ongoing models of funding. Again, this is state and national divide, I suppose. And then workforce and high turnover, which is, always there. Specific challenges. So aged care home lockdowns, a lot of COVID still happening. Yeah. And then things like larger corporates want to standardize their approach across their homes across the state. So we've done a few things to help. Hybrid events, breakfast forums, promotional video, articles, super users meetings, updates to LHD and New South Wales Health, really the opportunity to collaborate and hopefully more co-commissioning in the future. All right, I want to finish off with evaluations. So as I said before, if we can show timely access to primary care, we would be super happy. And we're partnering with the University of Sydney, Meredith's team, with 2 studies. So one is really looking at the human factors approach on how this actual technology will be used in general practice and the residential aged care homes. And the other one is an MRFF grant, really to look at the service and compare and contrast it with other PHN's approach, I believe. That's me.
Thank you. Thank you very much, Ken, and the Sydney North Health Network team. Really looking forward to working with you more on those important questions. And as a GP working in this area and doing a lot of virtual care now post-COVID, I really feel for my colleagues being a part-time GP and not visiting as much in person anymore, that I could be supporting if virtual care was enabled within our practice for people that lived in residential aged care homes. So I see exactly what you described, that this is not going to replace the need for GPs to have that personal and in-person relationship with residential aged care homes, but colleagues in group practices could be doing a lot more to support the visiting GPs and actually sharing the care with the whole practice team, with nurses and allied healthcare professionals in that team as well. So we do hope that this is going to continue to work and be taken up. Thank you. Right, so our next presentation is going to be from Dr. James Hardy. Yes, thank you. And Dr. James Hardy is a staff specialist geriatrician and head of department at Royal North Shore Hospital here in Sydney. He's the director of the Aged Care Rapid Response Team, and which is a home visiting service for older people, and we're going to hear about that. And Dr. Hardy is also a clinician representative on the Health Services Advisory Council at the Ministry of Health. So he'll be telling us about virtual care approaches to aged care with a focus on the Northern Sydney LHD. So thank you and welcome, James.
Great. Thank you, Meredith. Thanks for having me. So, as mentioned, I'm going to talk a little bit about our teams and our general approach to aged care outreach in the district. First, I just wanted to make a little plug, because really there isn't a broad approach across all LHDs for aged care outreach. We have teams, we're very lucky here that we've got teams that can actually go out and see people in the community. That we're fairly well funded, we're fairly well organised, but a lot of New South Wales doesn't have that. And, you know, we'd really like to see that rolled out everywhere, similar teams to ours. So really we need teams to be, these sort of teams to really be specialists. They need to be aged care experts. We need to have multidisciplinary teams similar to ours. We have nurses, geriatricians, we have physiotherapists. But ideally, I'd like to see some state and Commonwealth funding to provide this, because really aged care facilities and people in their own homes really need this sort of support. And we've seen during COVID and ongoingly with COVID that, you know, that the healthcare access for people in aged care facilities and in their own homes who can't easily come into hospital is relatively limited depending on where they live. So really briefly to touch on what we do, I'm going to talk mostly about acute outreach teams in our district, but we also have 2 other programs. One of them is a GP geriatrician liaison service, where we have geriatricians who are dedicated to talking with GPs about patients who are either very frail and at risk of coming into hospital or have come into hospital, and we'll target those particular patients and those particular GPs based on some of the data of those people who are coming in frequently. And our geriatricians can go out to the GP's offices, talk to them. They can do joint visits with the GPs, joint clinic reviews, and provide advice to the GPs to see what can we do to keep that person safe and well at home. So it's more of a subacute and sort of preventative type program. And we have 3 geriatricians across the district who do that. We also have a palliative care program where we have nurse practitioners who will go out to aged care facilities. And that's either for patients who've been in hospital recently and might have a terminal condition and need ongoing care in the community, in the aged care facilities, or it might be people who are already there and haven't actually come in but are at risk. And so that's another program that we have that we can reach out to some of those aged care facilities. I'm mostly going to be talking about our acute aged care outreach teams. So these are across the whole district. We've got my team, the Aged Care Rapid Response Team, in the Lower North Shore and Ryde areas, in the yellow and the green. In the yellow area, we have the orange area, we've got the Grace team based at Hornsby, and at the beaches, we've got the Brace team. All three of the teams are largely harmonised now. We do largely the same things. I'm going to play you a brief video really to demonstrate the sort of things that we do.
Welcome to a short video about the Aged Care Rapid Response Team. The Aged Care Rapid Response Team, known as ART, sees older people living in their own homes and in residential aged care facilities on the Lower North Shore, Ryde, and Hunters Hill areas. Our team of geriatricians, senior nurses, and physio provide triage assessment and treatment to older people who may otherwise be transferred to hospital. ART aims to reduce the number of avoidable emergency department presentations by providing alternative options to hospital transfer.
Audio off, I can talk through the visuals, so you can see what happens when I play it again. If it doesn't, I'll just try to explain it.
For those experiencing an acute medical condition, functional decline.
Okay, perhaps I'll describe what we do. So basically, we will take referrals from anyone really, whether it's GPs, worried family members, the patients themselves, and we will essentially go out or do a video conference, work out what's going on, try to treat the person where they are. And we really will take anyone really who's at risk of ending up in hospital in the next little period, so next few days potentially. And we deal with conditions like pneumonias, heart failures, falls, delirium, you name it, anything that's really common in older people. As I mentioned before, we've got physiotherapists, we've got nurses, we've got geriatricians, an aged care registrar, and each of the three teams across the district have the same basic composition. The sort of things we can do include blood tests, so we'll go out and take some bloods. We can do intravenous antibiotics. We can refer on to our hospital and the home service for ongoing antibiotics. We've got good arrangements with local mobile radiology services, and so they'll come out and do x-rays for us. We can get ultrasounds in the nursing homes. We can do ECGs, bladder scans, you name it. So the whole aim really is to keep people safe where they are, because we know it's pretty risky for older people to end up in hospital. Lots of complications can occur. So that's really the basis of what our teams do. In terms of technology and the virtual side of things, in 2019, which was very nicely timed, we did a pilot of video conferencing to aged care facilities from our team. And so we selected, I think it was 3 or 4 nursing homes to start with, and then we expanded to about 15. And it went pretty well initially. So then when COVID hit, we said, okay, we're going to roll it out to everyone. And it just so happened that the very first nursing home in Australia to have a COVID outbreak was Dorothy Henderson Lodge, which was in our district, in our area. And so that was a perfect example where we used a lot of video conferencing to manage a lot of the patients there. We're also fortunate that we had a GP who was placed in the nursing home at the time. And so we would video conference to that GP, provide specialist geriatrician advice while the people were undergoing either sort of standard medical problems or COVID itself. So that actually turned out very well. We've now expanded that further. So we now do video conferencing to community-based patients. So we can video conference to people in their own homes. And we expanded even further to New South Wales Ambulance. And I guess the main point I'd make about the video conferencing is that it really is an important triaging platform. So previously we'd take a phone call, someone would say, oh, I'm really worried about this particular person. You'd hop in a car, you'd drive for 30 minutes or 45 minutes to get out there, you'd have a look, and either they were too sick to be managed where they were and had to come in, or they weren't particularly sick and maybe this wasn't as urgent as we thought. Whereas now with video conferencing, we see virtually everyone straight away within minutes of them calling, and we can see straight away, is this person sick or not? Do we need to go out there? What do we need to actually do? I did this just today. We had a video conference with someone in a nursing home, and we could see that he was well enough to wait for an hour or so before we could get out there and see him in person. So the video conferences made a big difference to how efficient we are, and obviously lots of savings in terms of cost of the environment of driving around all over the place, and the stress of patients having to come in and be seen in hospital. So the ambulance project was really rolling out to the local ambulances in our area. And we gave talks, we handed out lanyard cards, we developed a QR code, and we spoke with New South Wales Ambulance, who made sure that all of their paramedics had smartphones which were capable of doing video conferencing. And they gave us logins for their ambulance arrivals board. So we can also see if someone's called an ambulance, what it's for, and we can bring that aged care facility or bring that paramedic and get on a video conference and see what's going on, and hopefully treat the person where they are. And that's turned out very well. The AMBOs and we are very happy with the collaboration between both sides. The other thing which we've done, again, sort of technology based, has been with the help of the PHN. So we developed a website for aged care facilities. So if they've got a patient with, say, shortness of breath, they can look up this website, click on the shortness of breath tile. It'll tell them, okay, these are the symptoms to check for. This is how you do an ISBA to hand over to their GP or to our team what's going on. Have you looked for things like an advanced care directive for this patient? So consider that. And while you're waiting for help, these are the sort of things you can do, interventions like setting the patient up, getting oxygen if it's appropriate, that sort of thing. So the other sort of thing we've done with this is have educational videos, including how to video conference, how to manage a whole variety of different conditions. And we've used this platform as a method of teaching aged care facility staff about various conditions. We've done one on heart failure, for example, how to detect signs of heart failure and how to run through that. And we're planning another one coming up on falls. So this, we didn't have time to present a lot of data, but just to give you a bit of a flavour, since we started collecting data for our team, this is aged care presentations to ED from aged care facilities, and you can see it's gone down pretty dramatically. And then since COVID and rolling out video conferencing, it's dropped even further and has stayed low in terms of number of patients who are coming in from aged care facilities each month. I probably will skip through the enablers, but essentially really was perseverance. And COVID itself did actually help in a way. I'm sure all of us experienced that video conferencing has really become the norm. Future directions, well, we're looking at remote patient monitoring. So in patients who have gone out and seen them with, say, pneumonia, can we leave some of these devices here that the facility or the patients at home can use to monitor their own health, and that we can remotely call back in and see how they're doing from time to time. The other sort of big thing we're doing at the moment is looking at after hours work. So we've recently rolled out all 3 teams doing evenings, and we're about to start doing weekend work as well. But that's been challenging and sort of keeping us busy at the moment. So that was a very quick Cook's tour of what we're doing in our district. And as I say, I'd like to see this type of service rolled out elsewhere because I think it works really well for the patients. Thank you.
That's great, and we've got a lot of lessons to learn from the LHD from the general practice setting, particularly in terms of how we approach telehealth and the fact that, like, I really picked up when you said you could see the patient straight away. Actually, the vision is so critical. I think it's a huge factor, and a lot of telehealth and general practice, you know, we still do a lot on the phone, and I just think the eyes of a video conferencing service makes such a huge difference to immediately assessing how sick somebody is. Anyway, so sometimes funding models drive these things as well, and I think that's probably going on in general practice as well. But let's move on to our next exciting speaker, and we have Professor Sarah Hilmer. And Sarah is a celebrated leader in the Sydney Health Partners Geriatric Medicine Clinical Academic Group that she leads. She's also a leader here with clinical pharmacology at Royal North Shore Hospital. Got lots of nice things to say. So, as well as being a conjoint professor at the University of Sydney, she's a fellow of the Australian Academy of Health and Medical Scientists, and she was recognised with a member of the Order of Australia in 2022 for her contributions to clinical and geriatric pharmacology. She leads research at the Kolling Institute, focusing on medication effects in ageing and frailty, which she'll be telling us more about today. So welcome, Sarah. Thank you.
Thank you very much, Meredith. And thank you for the opportunity to talk today. So today I'm going to talk with the hat of the chair of the Sydney Health Partners Geriatric Medicine Clinical Academic Group, and talk about how we work to bring together consumers, multidisciplinary clinicians and researchers to improve the care of older people, and how we can apply this to virtual care for older people. So the Sydney Health Partners Geriatric Medicine Clinical Academic Group is a new group that started 2 years ago, and it consists of multidisciplinary clinicians, academics from the University of Sydney and its affiliated medical research institutes, consumers, and the thing that we all have in common is that we're involved with the care of older people across settings, including primary care, in areas served by Sydney Local Health District, Northern Sydney Local Health District, Western Sydney, and Nepean Blue Mountains Local Health District. And what's quite special about our CAG is that it's focused on a population rather than a service. So we focus on the care of older people, whether they're in hospital, at transitions of care, or in the community, including residential aged care. It's also quite exciting because it is the first cross-institutional group in geriatric medicine or ageing within the Sydney Health Partners institutions. So I think as our community ages, the importance of bringing together clinicians and researchers and consumers who really have a focus on older people has risen to the top. And we're delighted to have the opportunity to work on this through our group. As I said, our group only started 2 years ago. We've grown our membership up to 150 members so far. Primary healthcare members are welcome. And if you had your phone out before for Meredith's QR code, feel free to join ours too. What do you get? You get newsletters and emails telling people about various events and opportunities. Do a lot of support for early and mid-career researchers who are interested in working in clinical research in ageing. And we're developing a database of research for junior clinicians to participate in. And we run a lot of seminars and training sessions on a range of things, from sort of international experts on frailty through to how to engage with older consumers when you're planning research. We've got a lot of emphasis on community and consumer involvement. We have a consumer representative on the leadership team. We have been involved in a number of Sydney Health Partners consumer engagement seminars, and we are actually doing a focused piece of work for early and mid-career researchers to think about how we can really train those people in consumer engagement for engaging with older consumers. And that's something that is probably just as important to primary care as it is to any other setting. In terms of competitiveness and impact, our main project so far has been developing a frailty index using data that's routinely available in the inpatient electronic medical record. And we have developed and validated this, and now we're trying to scale it up and implemented it, not only across RLHD, but also across others. We put in a large $5 million grant in the hope that someone will pay for it apart from RLHDs. If not, we'll come back to RLHDs. Collaboration is a major priority. We had a strategic priorities meeting at the end of our first year with a range of people, many of whom are in this room, including Meredith, to really talk about what was important for us to do. And we engaged with a number of different networks that have complementary needs. Sydney Dementia Network is an obvious buddy, and we actually set up a buddy matching program where we could link early career clinicians and researchers to try and do projects together. We also have some cross membership with the virtual care clinical academic group that you'll hear from in a moment. And clearly the primary care network is an obvious partner too. So how can we support virtual aged care? I think we could help with building capacity and capability in this space, and there's potential for another buddy program right here, particularly people who are interested in doing research projects that need geriatric medicine expertise. We can be a key to LHD partnerships, especially for transitions of care. And James talked a little bit about collaborative care, and there are other models that we could use for sharing information across transitions, both coming into hospital and going out of hospital. And the other thing that we really provide is expertise in implementation of comprehensive geriatric assessment. We have every clinical academic affiliated with Sydney University who is also a geriatrician in our CAG, as well as a number of lead clinicians from across the partnership. And we can help with medication review, management of frailty, falls, dementia, and delirium. And I'm just going to show you some work that we've been doing, looking at tools to identify and minimise the functional burden of medications. And this really is about using some virtual care to bring these tools to the bedside, and there are potentials to integrate it with the virtual care service that you're talking about. So it's all very well to know that once you're on 5 or more drugs, as an old person, you're in trouble. But at the end of the bed, that doesn't really help you, because which 5 do you keep and which of the other 5 to 8 do you get rid of? So in order to look at this a little bit more closely, about 20 years ago, I developed an equation called the Drug Burden Index, or DBI. And this is a pharmacological measure of an older person's total exposure to medicines that have an anticholinergic and sedative effect and impair physical and cognitive function. So the idea is it's not just the number of drugs, but the type and dose of drugs that determines their risk. And these are the drugs that slow you down physically and mentally, and you might just think you're getting old, but actually there might be a reversible cause, which is a drug that you could de-prescribe. So with Lisa O'Donnell, who is sitting in the audience here today, we've developed some software to deliver this drug burden index at the bedside. This is called GMEDS. It's got its own QR code if you're really on fire with your phone today. And it has a number of tools, and one of them is a drug burden index calculator. You have to type the person's drugs in, and it will give you a report that gives you an idea of how high their index is, which drugs are contributing, and you can think about what you might like to do to reverse any drug-related functional impairment. We've evaluated that in a cluster randomised controlled trial, including a process evaluation. It's now freely available to registered Australian healthcare practitioners for clinical care, and it's being used widely by pharmacists, nurses, and doctors. And we have also recently made a version for residential aged care. We've also implemented it in the hospital, and it's automatically calculated for every older person in hospital and plotted on the usual EMR between the flags format. And when we do calculate in hospital, we provide support so we communicate it to you when the person goes home. What's the person's drug burden index? What drugs are contributing? What do we do about them? Did the patient agree? And what do we need the GP to do? So finally, I just point out that there are really great opportunities to implement this through a virtual care model. This is a program that Len Gray led from Queensland about 10 years ago, and he was been really a leader in geriatric telehealth. And it was about using telehealth medication reviews, getting pharmacists and geriatricians and GPs to collaborate to really learn from each other and just collaborate through the video online format. And it was very clear that each professional group brings their own angles and can learn from each other. And this platform was a really good way to come together. So that's all I was going to say. I very much look forward to working with you through the Sydney Health Partners Geriatric Medicine Clinical Academic Group. Thank you.
Thank you, Sarah. So I'll move straight on. Our next speaker is Dr. Liliana Lorenzo, and she has a background as a general practitioner, a Master of Public Health from Harvard University, PhD in Digital Health. Lots of accolades here for Liliana as well. She's a Senior Research Fellow at the Westmead Applied Research Centre and has been awarded an NHMRC Emerging Leader Investigators Grant, an Honorary Future Leader Fellowship from the National Heart Foundation, and is also one of our new Horizon Fellows at the University of Sydney. Her current research that we'll be hearing about today focuses on using digital health to promote behaviour change, patient-centred care, and primary and secondary prevention of chronic conditions. Over to you, Liliana. Thank you.
Thank you, Meredith, and thank you for the invitation to present here today. I'm going to talk about work that has been funded by Sydney Health Partners Virtual Care Clinical Academic Group, and Adiola is the first author of this of this work, and she's here today in the room. And we were trying to explore strategies for management of acute patients by GPs in coordination with hospital services. And obviously, we know that GP involvement in remote management of these patients can decrease emergency department visits and hospital admissions. And during COVID, it was an interesting time where these GP advice lines kind of proliferated across Sydney. And they were basically phone services allowing GPs to easily contact the hospital for advice on specific patients, understanding whether they needed to go to hospital or could be managed in the community. And then when there were antivirals, also understanding how to manage antivirals for specific patients. And so we were trying to understand how this fits within the GP workflow. So understanding needs and strategies for managing these patients, but specifically focusing on these GP advice lines and understanding how they were implemented at various facilitators. I won't go into detail of the methods. We did a bunch of interviews to GPs and other healthcare professionals. 6 GPs overall, 2 consumers, and health service managers or healthcare professionals. Long interviews, so people had a lot to say, which was really good. And we covered 3 main regions, Northern, Central, Eastern, and Western Sydney. So this is the interesting part. So this was one of the themes, focusing on the GP needs to keep acute patients out of hospital. You won't be surprised to find that one of the most mentioned aspects was the need for better care coordination and continuity of care, and that's communication with the hospital. Participants mentioned the need for timely decision support and advice, particularly in terms of acute conditions. It was important for them to be able to access advice right there and then. Awareness of existing support and clear referral pathways was also mentioned, timely access to imaging and pathology results, and an adaptable funding model. So allowing for remote monitoring, for example, of these patients in the community. And then the other big thing was around factors influencing implementation and adoption of GP advice lines and virtual urgent care. One of the main aspects, that like the first and the bottom one. So the first one, you kind of need to evaluate these models of care. Participants mentioned a lot the quintuple aim, so understanding the healthcare provider experience, the patient experience, outcomes, and cost efficiency, but also equity was mentioned a lot. And that's really important in terms of virtual care, not exacerbating disparities. And that was connected to ongoing funding. You kind of need to evaluate to then be able to go and ask for more money and scale up of these models of care. Another sub-theme was that the support needed to be tailored to GP identified needs and workflows. And so there was mention of the importance of ease of access and use. GPs are very time limited in terms of their consultations, and so we cannot overburden their workflows. The real-time availability, again, that ability to have support right there when they have the patient in front of them. Having the feedback loop to GPs, and there was a lot of mention of when patients go to hospital, often GPs lose contact and track of patients, and then they have to kind of chase for information. And so it would be important in a model like this, and it was indeed implemented like that, having that feedback loop to GPs to tell them how their patients are going. The availability of different information and communication technologies. So phone calls were great and worked really well during COVID, but a lot of participants mentioned video, as you were saying, Meredith, would be great. And other interesting ones, and I'll show you a few quotes as well, mentioning more automated aspects like chat-based and text-based support as well. And then easy referral to urgent care, imaging, pathology, that was mentioned as well. Trust in the clinician handling the calls. For this specific one, there was a lot of talk about having a GP on the other side to better understand what the GPs in the community have in terms of resources, and so the advice is more targeted based on that. Having GP involvement in design and implementation, and then consumer awareness, consent and trust, really important when GPs are making these calls, kind of informing the patient that this is going to happen and where the information is going. That was it. I have just a few quotes here that I think are interesting. Obviously, referrals could be avoided if you could just ask 1 or 2 questions to the specialist, and that's why the GP advice lines were created. The new innovative models of care are really not well supported by our funding models, and so that needs to change that. People mentioning ChatGPT, and why not use that to support and provide information to GPs where needed. And then using our smartphones a lot better. So the telehealth, video, audio, uploading images, videos, screen sharing, all of that, we could be doing that a lot better now. The learnings from these can be easily transferred to nursing homes, and some of that work is already in place to avoid unnecessary ED transfers from residential aged care, and then making sure that access and equity remain front of mind. And that's it.
Liana. And I've been a little remiss in my time management. We might go over a couple of minutes. If anyone needs to leave, please do make your way out to the lecture theatre or farewell online, but we might run over by about 3 to 5 minutes, I think, so that we can hear our next exciting speakers. And I'd now like to welcome our final presentation for the afternoon. Firstly, Emma Hornsby, who's the nurse manager of the virtual care service at Royal North Shore Hospital and an expert in this field. She's been a registered nurse for about 17 years, working both in Australia and internationally, and has been working in leadership roles with nurse management for the past 5 years. And joining Emma today also we have Jason Levy, who's a physiotherapist for the virtual care service at Royal North Shore Hospital. And since 2020, Jason has been working across a variety of hospital and rehab settings, and he spent the last 9 months combining his interests of exercise therapy and technology to develop a virtual physiotherapy model of care for the Northern Sydney LHD. Emma and Jason will be talking about the Northern Sydney Local Health District Virtual Care Service and the Frailty Service. Thank you very much. Is that your thing?
Okay, good afternoon. My name is Emma and I'm the Nurse Manager of Northern Sydney Local Health District Virtual Care Service, and this is our Senior Physio, Jason Levy. And we're here today to talk to you about the Virtual Care Service and the Virtual Frailty Programme. I would just like to start by acknowledging the traditional custodians of the Northern Sydney region. Their spirits can be found across the region, and we honour their memory of their ancestors and elders, both past, present and emerging. Today I'd like to give you a brief oversight of the virtual care service and its model of care, and Jason will be discussing the physio program in the virtual care service, going through discussing frailty, how it's recognised, and what the virtual frailty program consists of, as well as reviewing patient feedback of the frailty service. So what is the virtual care service? The virtual care service delivers healthcare services to individuals who require urgent acute care at home. We employ a range of techniques, including remote patient monitoring, telehealth and video services to provide access, triage, care and linkage to community-based health services and primary healthcare providers. We work closely with Ambulance Service New South Wales, triaging referrals from paramedics and the VCCC to accept patients experiencing urgent but not life-threatening conditions that can be managed safely with the virtual care service, preventing unnecessary ED presentations. We accept referrals from GPs and from current inpatient hospitals within Northern Sydney Local Health District, reducing inpatient length of stay for care that can be managed in the community and virtually. And our two main service priorities are being ED alternatives and hospital substitution. We work Monday to Sunday, 8 till 8, 365 days a year, and we have a centralised intake number for our referrals. The modality of care we currently provide is video conferencing and remote patient monitoring. We're currently working at upskilling our virtual care nurses to provide that once-off intervention that would ensure patients receive the right care timely and potentially mitigate an ED presentation. We incorporate a multidisciplinary approach, working collaboratively with our GP BMOs, registered nurses, social workers, and of course our physiotherapist. I'll now pass you over to Jason to discuss the virtual care physio service.
Thank you, Emma. I'm Jason, the physiotherapist for the virtual care service. So, echoing our service priorities of ED alternatives and hospital substitution, The VCS service offers short-term physiotherapy delivered virtually. The main aims of the service are to facilitate early discharge, reduce ED representation, leverage technology, linking, triage, and prioritise care, empower research, and implement evidence into practice. We identified frailty as a target area for our service as research highlights the strong association between frailty and increased risk of ED representation. So frailty is broadly defined as a common syndrome that occurs from a combination of deconditioning and acute illness on a background of existing functional decline that is often under-recognised. Frailty increases one's vulnerability to physiological and pathological insults, increases risk of post-operative complications, increases length of stay, risk of unplanned readmission, increases rate of functional decline, and increases the risk of falls. What we know about frailty is that it can affect up to 25% of people aged 70 and above, and in NSLHD this equates to approximately 26,000 people. As frailty is linked with increased rates of falls, we were able to analyse a data set for individuals aged 70 and above who had had falls and found that 10.5% of these individuals were readmitted to hospital within 4 weeks. In Northern Sydney, the use of the Frail scale was used to determine one's level of frailty. Frail scale is a 5-point scale that scores one's level of fatigue, resistance, ambulation, illness, and loss of weight, which then classifies them as frail, pre-fail, or robust. Our service created a frailty pathway, where if a patient is determined as frail and ED or on the wards, they would then be referred to our service for follow-up virtual care at home. An initial virtual physiotherapist assessment is performed in which any concerns, particularly regarding safety at home, can be identified. If there are no concerns, the patient engages in a 2-week virtual frailty program and on discharge receives advice and education regarding ongoing frailty management in the community. If there are concerns identified for the patient at home, these concerns are then escalated to our medical team who can review and determine whether the patient is suitable to continue with the virtual frailty program or whether they need to access higher level face-to-face care. We ideally aim to avoid ED after identifying any patient concerns at home and consider referral to the hospital and the home service or try admit patients directly to the ward or into private rehab. Furthermore, if any patient deterioration is identified whilst under our care, we follow the same medical escalation and avoid ED pathways. The virtual frailty program is provided through the My Virtual Care platform to facilitate video calls with patients and their family or carers when required. Patients receive care for a maximum of 14 days, which focuses on education regarding frailty management, falls prevention, prescription of an evidence-based exercise program, and linking them in with other appropriate community-based frailty services and resources. As mentioned previously, the service aims to avoid ED representation for any patient that may be deteriorating at home by utilising the face-to-face hospital and the home service, admitting directly to wards and referring to private rehab as needed. A barrier to the facilitation of our service for this population group has been the use of technology. To ensure that patients with frailty are able to engage in our service, we utilise family members, friends, carers, and occasionally loan iPads to ensure that individuals who may not be experienced with using virtual modalities are able to engage in our program. Since May of last year, our service has been referred 108 patients and the feedback to date has been positive. On discharge from the service, all patients have reported that they have been provided with adequate information and resources to continue their care and frailty management at home. Furthermore, over 75% of patients have reported that the virtual consultations have been as good as face-to-face ones, which shows how this emergent area of work has enormous potential to grow. Thank you. I'm not sure if there's some question.
Yes, excellent. All right, so I think we got there. Oh, yes, I think we actually sadly don't have time for questions in the room now, but we do have some refreshments afterwards, so you can catch up with our speakers if you're staying on for a little bit with us there. Apologies to the people online, but if you send your questions to me, I'll make sure that people can answer them and we'll get them back to you. So thank you again to all of our speakers today. Terrific insights, a really important area that everyone's working in, very important for the community and just improving the way older people can access healthcare services with digital technology and new models of care that support better primary health care is what we're all here to talk about and support today. So thank you for coming along. And remember that you're all very welcome to join the network. Another little plug there. Use that QR code, and there's another QR code, of course, which is our event evaluation form, and we'll send that all to you afterwards anyway. But your feedback is as always invaluable, and so if you want to help us improve events, send us some feedback. And then finally, a huge thanks to all of the wonderful people that helped put this together today. Faye Hurwitz and the Kolling team, Nicola Abignano and Susie Redfern from the Networks team, and Samir Alkir, our fantastic Community and Primary Healthcare Senior Project Officer, and Alexandra Ivanova, pardon me, Alexandra, mispronouncing the surname, who gave us some great eHealth AV implementation support. So goodbye to everyone online, and for those in the room, please do now join us for some refreshments and a chat with your colleagues and friends, and I hope to see you at the next event.